honor is Dr. R. Balasubramaniam. He is the chief nephrologist at Kauvery Hospital, Chennai. He has 19 years of experience behind him, during when he has performed 500 renal transplantations, including living and cadaver transplants. He has 75 publications and presentations in various national and international forums and journals. A very warm welcome to you, sir. Our next panelist is Dr. K. Abhirami, nephrologist and urologist science at Kauvery Hospital in Salem. She has obtained her super specialty degrees from AIMS, Delhi, Royal College of Physicians, London, and University of Toronto, Canada. A very warm welcome to you, Dr. Abhirami. Our third panelist for the day is Dr. T. Rajarajan, consultant nephrologist with the Trichy branch of Kauvery Hospitals. He has completed his DM from Stanley Medical College in Chennai and has over 10 years of work experience. A very warm welcome to you also, Dr. Rajan. So before we actually proceed for the discussion and open the question and answer box for our participants, our three panelists would like to give small presentations on the subject matter. And I may first invite Dr. Rajarajam to speak on acute kidney injury. That will probably help us to understand how to stay safe and prevent causing damage to our kidneys. So over to you, Dr. Rajarajan.
First of all, thank you, Soma, and happy Women's Day to all the females who have made this life beautiful for both men and women. And as beautifully narrated by her regarding the World Kidney Day and the kidney functions, they just go into the pathological kidney states like acute kidney injury, which is one of the most important aspect and also silver line in nephrology, because if treated early and correctly, kidneys may revert to normal. So, first of all, happy Kidney Day, World Kidney Day. This is being celebrated every second Thursday of March. It has started by ISN in 2006 and it's been continuously spreading every year to spread awareness among the populations. So, and once again, greetings from Kauvery Hospital, Trichy. So, my focus of talk is acute kidney injury. This is a syndrome characterized by sudden reduction in the parenchymal function of the kidney, as evidenced by rise in creatinine, which is a marker of kidney function, which my subsequent speaker will elucidate, and reduction in urine output of less than 400 ml per day or 30 ml per hour, which is usually but not always reversible. This produces a disturbance in water, electrolyte, acid balance, and nitrogenous waste products and blood pressure. So this is a syndrome characterized by sudden reduction in parenchymal functions. The duration will be hours, 2 days. Right? Patient will be absolutely all right hours or days before suddenly develops renal dysfunction. It's called as a acute kidney injury. So to know about the causes of kidney injury, let me have the brief anatomy, and we have a paired structures of kidney, which is 150 grams and presented in the both loin, and it is supplied by the renal artery and drained by renal vein. It has a draining system called ureter that drains into the bladder, and then again urethra, which expels the urine out. So the cause of the acute kidney injury, sudden worsening of kidney functions, might be due to your pre-renal component, that is the cause that is away from the kidneys. So something kidney getting burnt of insult from the secondary causes like sudden or severe drop in blood pressure, either in the case of hemorrhage or fluid loss in the form of due to diarrhea, vomiting, and also some serious illnesses which compromises the renal flow to the kidney like sepsis or liver disease and cardiac failure. Another important pattern cause is intrarenal, where the damage occurs intrinsic to the kidneys. Kidneys can be damaged in varieties of ways like inflammation, toxins, drugs, infection, and the problem in the renal vessels like thrombosis, etc. Third important cause is the post-renal, like there is obstruction to the flow of the urine, either in the ureters, both ureters, or bladder outlet, either in the bladder neck or in the urethra. So that causes might be stones, tumors, enlarged prostate, or extrinsically obstructing the flow system like hematoma, like anything, or tumors. So this is a broad classification of acute kidney injury. So what are the symptoms for the common persons? Know about the symptoms. There might be a reduction in production of urine. Always is not be the criteria for diagnosing acute kidney injury, but certain acute kidney injury presents with normal urine output also. Another one is difficulty in breathing, fatigability. There might be a weakness, mental confusion, vomiting. These are all the symptoms pertaining to renal dysfunction, either acute or chronic, but acute being a dramatic. So these patients have these complaints often heard. So epidemiology wise, we have three types of acute kidney injury for our better understanding. One is community acquired, like patient having a diarrhea or vomiting outside, or patient sustain any infection and coming to the hospital, or trauma leading to a lot of blood loss. So the incidence is quite low. That's 1% in total incidence. That is, so often the cause is single, and overall mortality rate is 15%. Hospital acquired, so patient getting admitted in the hospital for some other reasons develop acute kidney injury, the incidence is higher, like 7 to 20% of hospital bed has an acute kidney injury. So this percentage is significant. So causes might be single or multiple. There are multitude of causes like hypovolemia, drugs, infection, everything can cause this kind of acute kidney injury. So overall mortality increased to 15 to 40%. And in ICU, where the patient is critically ill, the incidence of AK is still more higher. That is 35 to 70%. The cause is definitely multifactorial, and the overall mortality rate is way high. That up to 80% in some studies have a mortality rate. Or these are all the risk factors like elderly, who are elderly, diabetics, dehydration, diuretics, heart failure, cirrhosis, hepatic dysfunction, chronic kidney disease, nephrotic syndrome, sepsis. These are all the risk factors pertaining to AKI, as well as infections, trauma, and drugs. These are all the risk factors which pertains patients to AKI. So for the benefit of classification and better understanding, and to have the uniformity of AKI, we have a class stagings of the AKI. One we use is a KDIGO staging. This is so stage 1 is the rise of creatinine more than 1.5 to 2 times from the baseline level, or the reduction in urine output of less than 0.5 ml per kg per hour for 6 consecutive hours is AKI. Is a mild form of acute kidney injury. Stage 2 is a more than 2 to 3 fold increase from baseline, and the urine output must be less than 0.5 ml per kg per hour for 12 hours. Stage 3 is more than 3-fold increase or requiring dialysis. This is a severe form of acute kidney injury, where the patient might be anuric for 12 hours, or the urine output is less than 0.3 ml per kg per hour for 24 hours. Why this is more important? As the stage progresses, that you find that long-term mortality rate is more as you progress from stage 1, stage 2, stage 3. So what are the patterns of AK? How the AK occurs? Like you have a yearly reversal. The transient AK is one entity where the kidney dysfunction will resolve in 48 hours. So another one is yearly sustained reversal. That means AK present for 7 days and then revert to the normal rate of function. This is yearly reversal. Late reversal is reversal after 7 days and sustained throughout hospital discharge. That is late reversal. And another one entity is relapsing AK, where the patient recovers from AK, again have a AK in the hospital episode also. So when you look for it, and this graphs also showing that how the patient's patterns of AK depicts. So the 5, 1, 2, 3 almost recover to normally, and again 4 and 5 we have a pattern like AK won't recover at all, and it may lead to chronic kidney disease. Before it was thought that AK was benign disease, now it's not so, as evident from the many studies. So these are all the complications. Once AK develops, patient will develop the complications of holy fluid overload. That is most important risk factor for mortality in ICU or hospital setting. And electrolyte imbalance, because kidney does all this job. Mr. Soma Basi explained about the functions of kidney. So once it gets deranged, this patient will have multiple electrolyte imbalance, and impaired immunity level comes down. This patient is more prone for sepsis, and again the outcome, the patient might again land up in chronic kidney disease. So treatment, how to treat the disease? Like fluid management, initially we manage conservatively with fluid management, dietary measures, and other treatment of complications like hyperkalemia, hyperphosphatemia, hypocalcemia, hyponatremia. These are all the electrolyte imbalance that will be treating. Once, if the patient doesn't respond to the medical treatment, we'll initiate on renal replacement therapy, either in the form of hemodialysis, hemofiltration, hemodiafiltration, or peritoneal dialysis. This is a big topic. I don't want to go into the detail of all these things. So depending upon the patient condition, we treat conservatively or by interventions. So as elucidated, these are all the risk factors for AKI: old age, valve depletion, cardiac failure, nephrotoxic medications, atherosclerotic disease, diabetes, which proteinuria, very important to note in this present diabetes epidemic, and underlying CKD, poor nutrition status, sepsis, eye contrast, this before any angiogram, for coronary angiogram or CT angiogram. If you do a dye, if you give a dye, that's a risk factor. This is a risk factor for AKI, and any major surgeries, vascular or non-vascular, and genetic susceptibility nowadays is gaining pickup for the risk factors of AKI. So outcomes, as before I elucidate, like AKI is not always benign. So the mortality of AKI is around 20 to 80% depending upon the setting of AKI. Dialysis requiring AKI in ICU has a mortality rate of around 80%. So once AKI, the patient may recover fully, recovery and full normal health. Certain amount of patients, around 30 to 40% of patients go for a non-recovery of renal disease. That is called as an acute kidney disease, what we call as an acute kidney disease. Like the duration of AKI from 7 days to 90 days. The patient having persistent renal dysfunction up to 90 days, we call it as an acute kidney disease. And once it crosses 90 days, we term the patient to be called as a chronic kidney disease. So those who are going into the acute kidney disease phase, 50 to 60% will end up automatically in chronic kidney disease. So chronic kidney disease, as far as now, we don't have any curative, we have only a transplant as a curative process, and we cannot cure the disease with medications. So chronic kidney disease incidence is 50 to 60% in AKD. So chronic kidney disease, again, it portends the high risk of AKI. And this chronic kidney disease and AKI itself is an important risk factor for cardiovascular disease. So you find that AKI is not benign. You have to be very careful, and astute treatment of AKI will save the patient initially. And depending upon his injury, patient may land up in acute kidney disease or CKD or end-stage renal disease. So our take-home messages. So for all who want to have healthy kidneys, you drink adequate quantity of water, 2.5 to 3 liters to prevent hypovolemia. Definitely avoid over-the-counter medications or unknown agents. These are the important causes of acute or chronic kidney disease. Avoid cigarette smoking and alcohol consumption. Avoid dehydration when you are having any diarrhea or vomiting. Never hesitate to visit the doctor if you are unwell. So don't overdo yourself by giving your own medications and all. Screen for your kidney health if you are a diabetic or hypertensive. Thank you for hearing.
Thank you, Dr. Rajarajan, for that very, very informative slide presentation. Chronic kidney diseases is what Dr. Abhirami will now talk about next. Over to you, Dr. Abhirami.
Good morning, everyone, and happy Women's Day. Can you see my screen?
Yes, ma'am.
Okay. Okay, so today this is observation of the World Kidney Day, which happens on the second Thursday. It has been alluded to earlier. So I'm just going to talk about the chronic kidney disease. Chronic kidney disease by definition is kidney disease which is present for more than 3 months, and we think it cannot be reversed. It cannot be corrected. So that is the definition of chronic kidney disease. So this chronic kidney disease is the one which we are all very familiar with. What we routinely used to call kidney failure, and patients are on dialysis and transplantation, it is part of this chronic kidney disease. But all chronic kidney diseases are not kidney failures, and that's why this new terminology has come up, not very new. So it has been staged into, divided into 5 stages, starting from 1 to 5. In stage 1, there are features of kidney disease, but the kidney function, which we measure using GFR, it is called glomerular filtration rate. It can be measured very simply using a blood test called creatinine. So the creatinine value can be converted into a glomerular filtration rate, which is a number using a mathematical equation. And there are many apps to do that. And that number gives a single window for the assessment of the function of the kidney, the main filtration function. So if the kidney function should be, the GFR should be 100 to 120 ml. So in stage 1, the GFR is normal, but the person has Some other evidence of kidney damage. It could be some structural problem in the kidney. They can have stone, they can have urine infection, they can have protein in the urine. So stage 2 is when there is a mild decrease in kidney function and the GFR is between 60 to 90 ml. Stage 3 onwards, there is a compromise in kidney function and the blood creatinine values start to rise. And depending on the severity, it goes from 3A, 3B, 4 to 5. So once the kidney starts to fail, what will happen? For that, we should first understand what are the functions of the kidney. This was alluded to by Soma in the beginning. We should all understand we have two kidneys. So we know it makes urine. So it's basically a filter. It filters out whatever is not required in the body and sends it out in the urine. This is something we all know. But what we do not know is kidney is not just a filter. It has a lot of other functions. It helps in production of RBCs. Kidney produces a hormone called erythropoietin, which regulates the production of RBCs. Kidney is very important for bone health. Vitamin D, which is present in the body, is activated by the kidney and then it maintains bone health. Kidney also helps in maintaining the balance of a lot of minerals, electrolytes, which are very essential for cellular function. It helps in having a water balance and it helps in regulating the blood pressure. So when the kidney function fails, all these functions start failing. So
Ma'am, one thing, your slides are not moving actually. So I just wanted to point it out.
I'm sorry. For me, it is moving. Now do you see it?
Now we see it, yeah.
So I think I'll not put it on screen and I will not put it on full screen. I'll just present it like this.
Yeah.
So coming to chronic kidney disease, in India, approximately 17% of the population is expected to have chronic kidney disease, starting from stage 1. Okay, not everyone is in kidney failure. So 17% is a big number. We should understand it's 1 in every 5 person is having chronic kidney disease. So with our huge population, the disease burden comes to 22.8 crores. And one another interesting thing about CKD, not so interesting, very sad actually, is the average age of people getting CKD in India is very low. In the Western countries, the average age of a CKD population is 60 plus. Whereas in India, the various studies have shown the average age of CKD is between 40 to 50 years. This is because of our metabolic risk. And we should understand diabetes, that is high blood sugar, and hypertension, high blood pressure. These two are the major causes for chronic kidney disease in India. And because we are becoming the diabetic capital and also we are metabolically different and we tend to get diabetes at a younger age. So chronic kidney disease also starts at a younger age. So what happens? What are the symptoms of chronic kidney disease? In the early stages, it's not symptomatic. So it's one of the silent killers. Unless certain diseases alone can produce a reduction in urine output. In those cases, we can pick up kidney disease very early. But majority of the kidney diseases, there is no reduction in urine output, but actually there is a change in the way we make the urine. So because of that, in the early stages, there are no symptoms. Only when the renal function starts decreasing to less than 50%, we start seeing symptoms. What are the symptoms? It can affect any part of the body, starting from the head to toe. We'll not go over all this. But as I said, only when the kidney function starts dropping below 50%, you start getting symptoms. Tiredness, swelling. Swelling is not seen in everyone. It is seen only if the urine output decreases. And then there's a change in the way you pee. So normally all of us healthy people in the young adult age make more urine in the daytime and we are continent in the night. We don't get up to void in the night. It's very unusual to void in the night in the young adult age. Children and old age, you can void once or twice in the night. So when that pattern changes, you void more in the night than in the day. That's one of the earliest symptoms of chronic kidney disease. Sorry. Okay. Once the kidney disease worsens more, like once the kidney function drops to less than 25%, then you get all the major symptoms. You start feeling very tired, not able to eat, start becoming breathless, not able to walk, not able to lie down because of breathlessness. And in the last stage, the urea and the creatinine, the markers of kidney disease, can affect all the organs in the body, mainly the brain. So you start feeling tired, not able to concentrate. You're very restless, either sleep too much or don't sleep at all. And also recurrent vomiting, not able to eat anything, fatigue and muscle cramps also you can see. So how to diagnose a chronic kidney disease? As I said, it is very asymptomatic to begin with. But the good thing is we know diabetes and high blood pressure are the commonest causes of kidney disease. So people who have diabetes and hypertension should get their kidneys checked at the time of diagnosis and again every year. And if there is some abnormality, the treating doctor would suggest how frequently you should get the test done. Diagnosing kidney disease, chronic kidney disease is relatively easy. All that you need to do is examine a person, get the blood pressure done, simple urine test and blood test. So you're getting a urine routine, urine protein, urine microalbumin, and blood tests like urea, creatinine, and electrolytes will give a diagnosis most of the times. Okay, you'll need an ultrasound to show that the kidneys are smaller. So in chronic kidney disease, because it happens over a period of time, the kidneys shrink. So that's one of the biggest marker of a chronic kidney disease compared to the other kidney disease. So you will constantly hear doctors telling your kidneys are shrunk, so there's not much we can do. Very rarely we might need to do a biopsy to diagnose a kidney disease, cause for the kidney disease. So how to treat? As Dr. Rajarajan said, chronic kidney disease cannot be cured. So it cannot be reversed, it cannot be cured. But don't lose hope. There are a lot of other things we can do to prevent the progression of the chronic kidney disease and lead a healthy life. So what are the things you need to do? So first is, because blood pressure and high blood sugar are the commonest causes, we should get your pressures and blood sugar controlled very well. The third important thing is to have a proper diet pattern. So what we normally recommend is, it varies from person to person, depending on the extent of the kidney function, the type of kidney function, the amount of urine they make, and the levels of the salts in the blood. It is very individualized, but in a broad picture, protein restriction and some diet restriction for potassium and phosphate is usually recommended. The most important thing is to avoid unnecessary medicines. A lot of drugs can affect the kidney, even the ones which we are, painkillers is a well-known drug which causes kidney disease. Now the awareness is improved, but there are a lot of other drugs, like drugs used to treat acid peptic disease, the gas trouble thing, and also certain antibiotics. So a lot of drugs can affect the kidneys, and sometimes the drugs will affect the kidneys if it is not used appropriately. You end up using them for a longer period of time, they're more than what is recommended. So please avoid any unnecessary drugs without prescription, without advice. And start looking at the urine and the frothiness of the urine and the color of the urine, and the water intake should be regulated according to that. So smoking is a big no. Everyone knows that smoking is bad for the lungs, bad for the, can cause cancer. But it is important to know smoking is bad for the kidneys also. It will increase the progression of the kidney disease. So you will go into renal failure faster if you continue to smoke or use any tobacco in any form. Smoking also affects bladder function, and it can cause bladder cancers. Then the doctor would prescribe medicines. One is, there are certain drugs to prevent the progression of kidney disease. This is again very individualized depending on the diagnosis. Nephrologist, you should consult a nephrologist to get advice on that. As I said before, the bone and the blood health depends on the kidney, and those things will require supplementary medications. That is also important to stop feeling fatigue and breathlessness. So these drugs are also important. Many a times patients come back and tell me, he's just given me a lot of vitamins and minerals. I don't know why I should take that. You should take that to keep your bones and blood healthy. So once you don't get the disease controlled, or if it continues to progress, then we call it chronic kidney disease stage 5. This is the this is the usual kidney failure we all hear about. And even here, there's nothing to lose hope. There are multiple treatment options, and Dr. Bala is going to talk to you about that. And finally, 9 golden rules for renal health. This is something Dr. Rajarajan also spoke about. And the World Kidney Day, the main purpose of it is to promote these 9 golden rules so that everyone can follow that and keep their kidneys healthy. Thank you.
Thank you, Dr. Abhirami, for that very wonderful presentation packed with information. We'll move on to the final presentation now, which is on dialysis and transplantation by Dr. R. Balasubramanian.
I'm sorry, I have to stop sharing.
Yeah, Dr. Balasubramanian.
Is my screen visible? Good morning.
Yes, sir. Yes, sir, it is.
Good morning and very happy Women's Day to all the wonderful women of this world. And thank you very much for hosting this program. And then my talk is going to be a continuation of what Dr. Rajarajan and Dr. Abhirami had spoken. Dr. Rajarajan spoke on temporary kidney disease, and Dr. Abhirami spoke on long-standing or permanent kidney disease. The end aspect, unfortunately, if the disease has progressed to an advanced extent where somebody is going to have a significant dysfunction of the kidneys, where the toxins accumulation is going to be significantly high in the blood, and the patient gets into complications because of this, then patients would need a dialysis treatment. And the pattern of dialysis, what we do, varies according to the clinical condition of the patient. Whether the patient is sick, he's in the intensive care unit, or patient has got other comorbid conditions like a heart disease, where the patient has a child who needs a dialysis treatment. Is it temporary kidney dysfunction or is it permanent kidney dysfunction? So all these things decide what kind of treatment a patient is going to need. As I told you before, it's done only in advanced kidney disease. Not every kidney dysfunction needs dialysis. In the initial stages, be it a temporary or a permanent kidney dysfunction, the patients are managed medically as told by Dr. Rajarajan and Dr. Abhirami. When it becomes significantly alarming, we need dialysis. And good news is that in a temporary kidney failure, or an acute kidney failure, the dialysis can be discontinued once the kidney function recovers. The recovery can be either complete recovery or even a partial recovery. Many a times patient gets into, the dialysis can be stopped. So many a times patient always asks us a question, once dialysis means lifelong dialysis, should I really go to it? That's a question what most of the patients and the attenders ask us. So in a temporary kidney dysfunction, dialysis is not lifelong. Most of the time, the kidney function improves and dialysis can be stopped. There are different ways of dialysis. We just get a few glimpses about all these different aspects of dialysis. What all of us know is a process where a patient comes to the hospital, his blood is taken out of his system and the blood is getting purified, and the purified blood gets back to the patient. That is called as a hemodialysis. He means blood. So anyway, you take the blood outside and then purify it and then send the patient back to the patient. This is called as a hemodialysis procedure. What you need is a dialysis machine which is fully computerized. We need a lot of chemicals. So we need a purified water. You need an artificial kidney that's called a dialyzer. And most importantly, the personnel who does the dialysis procedure. They're called dialysis technologists, who are well trained to carry out the procedures under various circumstances in the hospital as well as in the intensive care unit. It's a very safe procedure. Like a lot of people used to get worried about dialysis, and then we need to do counseling to ensure that the benefit of dialysis is much more than the risks involved in it. And once the patient gets into the dialysis procedure, most of the patient comes back and tell us, it's very unfortunate that I had to get worried about this procedure. I postponed the dialysis. I should have started it much before than what it is. So most of the patients who have especially a long-standing kidney disease, they undergo a dialysis session 3 times in a week, and each session lasts for 4 to 5 hours. That's a dialysis machine onto your left, fully computerized dialysis machine. You go to any dialysis unit, you find enough and more machines, and then patients are hooked to the dialysis machines. And compared to the quality of machines what we had long before, and now all the machines available are fully computerized, and a lot of monitoring systems are available. Suppose if the blood pressure drops or if the blood flow gets stuck, the concentrate gets emptied, and so on and so forth. Various situations where the machine automatically gives an alarm, the safety of the patient is highly ensured. So that's a dialysis machine. A patient is undergoing a dialysis procedure, and that's an artificial kidney. You have a small bundle of fibers which have it, and these fibers you have like a hair-like fibers, what you see inside this. There are thousands of fibers which are present in this artificial kidney. And inside these fibers, the blood gets in. And in between the fibers, the dialysis fluid gets in. And then all the metabolic waste, they get removed through the process of diffusion, what we call it technically. What you need in a long-standing dialysis is, so we have to take the blood outside. So we need a system in which you can take the blood outside from the patient. Many times when you go to a hospital where blood is withdrawn for any investigation, you find that a needle is poked into your vein, and then the blood, where the needle is, there is a suction applied to the needle so that the blood comes out very, very slowly. But when you do a dialysis, you need blood at a higher pressure. So to facilitate this process, we create what is called as a fistula, especially when somebody needs a long-term dialysis, where you connect an artery and a vein under the skin. Nothing is visible outside, so that the high pressure of the artery is transmitted to the vein, and the vein gradually becomes bigger. You see a big dilated vein, what you see in the forearm, and from where we can take the blood and then you can purify it. Generally, we can't puncture an artery, so because of which we connect an artery and a vein, and the high pressure of the artery is transmitted to the vein. So vein becomes what is called as an arterialization of the vein. And we can puncture the vein and take the blood for dialysis. And 1 minute. And this is the way in which you cannulate the artery and the vein, and you take the blood outside and then you purify it. You also need suppose if somebody has got a temporary kidney dysfunction where the patient that need not think of a long-term dialysis, you can do what is called as you can insert certain tubes called catheters. And these catheters can be inserted either in the neck. It can be a temporary catheter. It's a jugular vein. You can insert the catheter under ultrasound guidance, or you can insert the catheter on the vein which is present below the collarbone. That's called a subclavian catheter. You can also put the blood in the leg vein called a femoral catheter. This is temporary catheters. There are some type of catheters which can stay on for a longer period of time. They're called perm catheter, permanent catheter, which can hold on for months together, and patient can get dialysis through these catheters. There are different forms of dialysis available, as Dr. Rajarajan said. The dialysis, what I had talked to you about, can be applied to patients who are stable, who have got a very good blood pressure. They can come to the hospital. They can even drive to the hospital, get themselves onto dialysis. They can get back. But a patient in the critical care unit who is on multiple supports, who has got infection, low blood pressure, these patients cannot be dialyzed conventionally, and they have got enough and more facilities available to dialyze these kind of patients. And they are called as continuous renal replacement therapy. The dialysis can be done in the bedside. It can be done over a period of 24 hours. All the waste removal, the removal of extra water, balance of electrolytes can be done through this machine. And that's called as a continuous renal replacement therapy. You can see a patient who is sick in the ICU with so much of monitoring that is going on, and the patient is on continuous renal replacement therapy. The next form of dialysis is called a peritoneal dialysis. The basic difference between a hemodialysis and a peritoneal dialysis is that in a hemodialysis, you take the blood outside, purify it, and send the blood back to the patient. In a PD, what we call as a peritoneal dialysis, called as a PD or CAPD procedure, we have a small catheter which is implanted inside the patient's abdomen under local anesthesia. The portion of the catheter is inside and part of the catheter is outside the abdomen, through which we send the dialysis fluid inside the abdomen. There's a cavity outside the intestine, and that's called as a peritoneal cavity. You can send the fluid inside the abdomen. The fluid stays in the body for 6 to 8 hours, and then the fluid is replaced. The process of replacement takes about 20 minutes, and it can be trained to the care provider at home. You need not require a doctor or a nurse to do the procedure. And the procedure can be done at 3-4 times in a day. This is the catheter inside the abdomen. You got a dialysis fluid that can be sent inside the abdomen, stay for a few hours, and then it can be replaced. There's also a machine available called a cycler. A patient can do the dialysis in the night when he is sleeping. You see a gentleman who is as comfortable as what he would otherwise be, getting on to a dialysis through a cycler in the night. So different ways in which it can be done. The biggest advantage of the dialysis to the abdomen is that it's a continuous dialysis, unlike a blood-based dialysis, which is an intermittent procedure. In a blood-based dialysis, patient comes to the hospital a couple of times a week. He stays for a few hours and gets back. Contrary to that, the abdomen-based dialysis is a continuous procedure. The fluid is always there inside the abdomen, because of which there is a better removal of water and waste products. Patient need not come to the hospital, not much of diet restriction. They can be on even normal diet, and safe for patients with heart disease and children, etc. Less infections and blood loss compared to hemodialysis procedure. Coming on to transplant, it's an excellent option for patients with permanent kidney failure. The most important thing is it's a foreign organ which is kept. Unlike many other situations where a deceased organ is removed, for example, an appendix is removed, a uterus is removed. Contrary to that, here in a kidney failure, especially in a permanent kidney failure, temporary kidney failure does not require a kidney transplantation because it's reversible. A permanent kidney dysfunction, if the patient is young and then has got no contraindications for a transplant, is the best option what you can ever have. Since it's a foreign organ, we all have an immune system which protects us from normal infections and malignancies. But that protective immune system cannot differentiate between a disease-causing organism and a life-saving organ, but it starts rejecting it. So because to prevent this rejection from happening, we need to take immunosuppressive medications to keep the immune system at check. But unfortunately, the other side is that if you suppress the immune system to a greater extent, the chance of infections are pretty high. So the transplants can be different ways. The common ways in which we do a transplant is called as a life-related transplant, where a loved one gives a kidney to somebody else. The other option is called a cadaver transplantation. If there is no near relative available for a transplant, you can register the patient in a portal where you are fit for a transplant without a donor, and then organs are allocated whenever there is a brain dead victim. A person who has an irreversible brain damage following an accident or bleeding inside the brain can be produced brain dead, and the awareness about brain death is significantly present now, and a lot of organs, including kidneys, can be transplanted. We can do transplants in children as well. We can take generally one of the mostly a parent is a donor here. An adult kidney has to be kept inside the patient's abdomen. We also can do a blood group incompatible transplant. In fact, initially people used to think that, as nephrologists used to think that for a transplant, the blood group has to be matching. O group is a universal donor, beyond which the blood group should be identical between the donor and the recipient. But these days, a lot of technological advances have come in where we can even transplant kidneys across blood groups as well. The best possible scenario is that we should realize that the kidney diseases are increasing in numbers, which is alarming, as Dr. Rajarajan and Dr. Abhirami had told. But fortunately, in spite of, suppose unfortunately somebody gets into an advanced kidney failure, don't worry about that. Dialysis is definitely a safer procedure, accessible these days. In fact, even if somebody cannot afford dialysis, the government has taken a huge step in providing dialysis free of cost in all the hospitals. We have standalone centers and private hospitals doing a great job in taking care of patients with kidney disease. The kidney transplant, which is supposed to be highly complicated and with a lot of risks involved with rejections and infections and so on, a lot of advancements have come in, and then because of which the success of transplant is more than 95 years. In fact, to tell you that all the viewers, in fact, I had a patient who came yesterday. This gentleman had a significant heart disease, had gone 2 valve replacements and other procedures as a child, and he needed a transplant. And then we transplanted him. His father is a donor 8 years before. He came back yesterday with his wife and 2 kids. It's a very pleasant sight for nephrologists to see, because that's a total rehabilitation what a patient with permanent kidney disease could have. In spite of all these things, the best way to handle kidney disease is prevention. Anybody who has a vulnerability, ensure that you prevent the kidney disease at any cost, as told by Dr. Rajarajan and Dr. Abhirami. Ensure that you have a safe kidney and then live happily and longer. Thank you very much for the wonderful opportunity.
Thank you, Dr. Balasubramaniam, for that very exhaustive talk. So I was listening to all of you. I was just wondering, because one point which came out clear was a kidney malfunctioning remains asymptomatic till quite a late stage. So it can be extremely overwhelming for anybody to suddenly discover that my kidney is not working. So in such a scenario, and now that we are also meeting on the eve of World Kidney Day, what exactly are those points that we should be, I mean, much of it you've also covered, it's overlapping also in your slide presentations, but in layman's term, what is it that we should be telling people who are maybe otherwise normal, healthy, or even those people who are already diseased with some other ailment, and they also stand the risk of kidney malfunctioning or dysfunctional kidney? I mean, what is the way to, kind of bring the people for testing themselves, or there has to be, because I mean, as you pointed out that we are the diabetes capital, we are the hypertension capital, and these are the main causes. But still, there is some kind of one feels that in our country, we don't go to a doctor till we are actually, via emergency treatment. Yeah.
Can I take the question?
Yeah, please, sir.
Yeah,
Open to all three of you. Yeah.
there are two sides of this coin, and one side is one definitely, especially in an allied community, the health awareness is definitely there. Master health checkups have become reasonably routine in most of the population, especially if somebody is a diabetic. Obviously, the diabetologist ensures that a full complete health check is done at least once in a year. So as patients with high blood pressure, heart disease. In which case, obviously, a subtle kidney abnormality can be identified in the early stage itself. That's point number one. And anybody who has symptoms of kidney disease, like any disturbance in urine or in passing urine, as Dr. Abhiram said, even large quantities of urine, frothy urine, blood in the urine, all warning signs of kidney disease has to be significantly identified and then managed. A lot of people think that hypertension is a heart disease. Hypertension is a kidney disease because kidney only controls the blood pressure. Many a times what we see is patients with high blood pressure goes to the cardiologist, gets a treadmill testing, echo testing, ECG and so on. But it is true that long-standing high blood pressure can affect the heart and the kidneys or the brain. But the root cause of high blood pressure could be in the kidney. So if any high blood pressure patients, instead of taking blood pressure pills, it is more important to find out whether the blood pressure is related to lifestyle related disease or it is related to kidney disease. And then before you take a medication, certain basic things like this, I'm sure the kidney dysfunction can be identified pretty early. Temporary kidney dysfunction, many a times patient goes to the hospital for some other thing and then it can be identified soon. Other people can take the question.
Yeah, would you like to add something, Dr. Abhirami or Dr. Rajan?
Yeah, it is not that difficult nowadays. The urine test, the blood tests are available everywhere. And it has become a part of screening protocols in any hospital admission. Anyone who comes into my ER for any problem gets admitted would get these tests done. So those things are there. But unlike what Dr. Bala said, I personally think people, at least in the peripheries, are still looking at high blood pressure and diabetes as something for which they have to take medicines. They see a doctor once and they just continue taking those pills and keep looking only at their blood pressure numbers and their sugar numbers. They are not on regular follow-up. So I think what is more important is to identify blood pressure and diabetes at an early stage. So you start screening for blood pressure and diabetes when you are 35 or younger if you have risk factors. So first thing is to screen for blood pressure and diabetes. Then if you have that, then you should start screening for kidney disease. So meeting a doctor or having a GP like in the olden days where the doctor knows all your problems and he remembers all your history, that kind of a general practitioner or a family doctor is a good idea.
Dr. Abhirami has illustrated well, actually. From my point of view, there are certain sets of patients who are at higher risk of chronic kidney disease or any form of kidney disease like diabetes, hypertension, obesity, and those who are overweight, that is obesity, and family history of kidney disease, anybody in your family having the kidney disease. So, and elderly people more than 60 years, these are all the subsets of patients who are prone to develop kidney disease. So such kind of patients like diabetes or hypertension patients, this is a very simple test that, as Dr. Abhirami told, it's an urine routine and blood test hardly costs around 200, 300 rupees, that's all. Not like other systems where you do the high-fi gadgets and all. So these, its awareness should be come from the patient side to check at least once in a 6 months for these kind of subsets of patients, and also from the treating primary physicians where they are in villages or there. They should come up with the investigations. Many times, maybe we'll be seeing some patients diabetes checking your urine sugar and blood sugar, not even once seeing the creatinine or urine albumin, which is the marker of kidney disease. So the awareness should be wholesome from the patient point of view as well as the primary care physician to detect the early kidney disease.
So, till what percentage of kidney functioning is considered to be safe? You know, we've also heard doctors saying that, when the patient came, 50% of the kidney was already not functioning. But the patient didn't feel anything. He was living like he was perhaps feeling okay and leading a normal life till something led him to diagnose this. So till what percentage of that kidney functioning would you consider is still kind of okay for an individual, and beyond this, you know, the threshold we can't cross?
No, I ideally we should have 100% kidney functioning. There's no compromise. But what we should understand is that if the kidney starts deteriorating, The remaining kidney starts overworking, and because of which the damage is progressive. It's not that somebody has got, say, 50% kidney functioning, it's okay. The 50 ought by itself, in spite of you doing whatever best you can, the kidney function starts deteriorating. So because of which we should ensure that we have a absolutely good kidney functioning. One more thing is that every test has to be interpreted with caution. What we have seen many a times is that people say, I do an ultrasound, kidney looks normal on ultrasound scan, so my kidney functioning is all right. But ultrasound is only a photograph. A photograph cannot tell the quality of a person, isn't it? Similarly, you cannot interpret just a plain ultrasound and then say kidneys are all right. Second thing is a creatinine, what is routinely tested in most of the labs as a part of master checkup or anything else, takes a creatinine, and the creatinine, as Dr. Abhirami told, will not start increasing unless he or she gets into stage 3 of kidney failure. So because of which a normal ultrasound, normal creatinine does not tell you the kidney is normal. So whenever any doctor, any patient interprets a test, please ensure that this test has to be appropriately interpreted by the nephrologist or your family doctor.
The corollary to that is, I mean, we do renal transplants all the time, and we are allowing living people to donate kidneys. So, I mean, we'd love to have 100% of the kidney, but we can function well with 50 to 60% of the kidney. Kidney is relatively forgiving, but as Dr. RBS was telling, once you take away the kidney from the donor, the other kidney does compensate. So, in that context, 50-60% of the functioning kidney should be good. That is what I mean is you don't have any disease and you give away one kidney, which means you're giving off 50%. The other 50% would be good if you maintain it properly and you take adequate precautions. But in a person with disease, a disease causing you to lose some kidney function, one is, as he said, the rest of the kidney is compensating for it, but it will not compensate for long. The second thing is whatever damage the kidney to that extent is going to damage the rest of the kidneys also. So that way, ideally, you should not have kidney damage. So losing 50% of the kidney as a donation is okay when you are healthy. And that is what the nephrologist will do. They'll screen and make sure you're healthy.
So what is the status of donation in our country, the kidney donation? Is there a long waiting list? Is it difficult to find a donor?
Yeah, we are doing second largest number of transplants in the world. Okay, that's great after United States. But our disease transplant rate, that is the cadaver transplant rate, is very, very, very low, abysmally low. And except like Chennai does very well, but in the rest of Tamil Nadu, if you see, the numbers are quite low. So the awareness about brain death and organ donation can be improved significantly.
Adding to the point, a study in India shows that only 10% of end-stage renal disease patients. End-stage renal disease is the one which the kidney completely gone out and needs some support treatment. So 90% of end-stage renal disease patients are not receiving any form of renal replacement therapy in India. Only 10% are receiving renal replacement therapy either in the form of dialysis or transplant. So every year, 250,000 patients average, on an average, are adding into the ESRD pool, of which 3,500, 5,000 or 6,000 transplants are going on in India. As Madam told, as Dr. Abhirami told, cadaver transplant is a large potential, actually. We have around 2.5 lakhs of road traffic. If you consider the road traffic accidents, insults in Indian average, 250,000 patients are going for a severe brain injury amounting to brain death, actually. So if it is 10%, if 10% has been converted into it, so many patients will be having a kidneys. So here the donation rate is only 0.1%, and compared to Spain or Japan, where the conversion rate is much higher. So this thing, the cadaver transplant program has a large potential and large reserve to supply for the kidney waiting patients. So this has to be promoted, and more conversion rate has to be there, and to bridge the gap and all. Presently, only 10% of the end-stage renal disease patients are getting dialysis and transplant.
The live donor awareness is reasonably there. But many times if you say that there's a kidney failure, then he needs a transplant, most of the families, they disown the patient. They don't even stop talking about this, unfortunately. And even if as nephrology, we tell them all these things are not going to affect the donor's health and so on, they still have a certain reservations in organ donation because the fear is understandable. But what as nephrologists we should do, or even transplant counselors should do, is that we could definitely get the prospective donors' family, sit with them, talk to them, make them talk to other patients who donated organs to their loved ones in the past and how healthy they are, how they lead a normal life. If we can probably do that, the live donation also will increase.
Our point of view, sorry to intervene.
No,
From
please
our point of view, to expand the donor pool, we have made a lot of innovations and technology has permitted us to go beyond the barrier. Before, initially, it was thought that blood group was a barrier for transplant. Now the barrier has been shaken. So we do a ABO incompatible transplant to increase the widen the donor pool. Again, another one, if there is a mismatch, there is another thing is a swap transplant, Domino's transplant. There are many innovations that has come on the way, and we are adapting to it to increase the donor pool. Also, there is some sensitized transplant, like HLA sensitized transplant. Everybody will be having an HLA antigens, like for the common persons to know. So that is causing your T cells to present as an antigens like. So if there is an antibody against that antigen. So we usually see the cross match between the donors and the recipients. The cross match is positive, and we immediately will turn down the donors. Nowadays, donors are becoming a very much rarity because of the increase in diabetes, hypertension, and comorbids among the donors. So from our side, we are making innovations to enhance the pool. From awareness, as Dr. RBS told us, the awareness should be coming from the patient side that many people will be running away. Actually, if you say that the patient is having kidney disease and he needs a transplant, next time, people will be coming in a groups or 5 to 10 people will be coming. Once they hear that the patient is having that end-stage renal disease for a transplant, next day morning, that everybody will go off actually. Who stays as a mother, father, and his wife or
on a lighter note, sometime before I told one of my patient that he needs a transplant, why don't you talk to your brother and sister, ask them to donate. He said, "Ayo, doctor, I only fought with them for a property dispute last month. I cannot ask them now." So on hearing that, I started telling that all my patients whose creatinine is probably stage 4, hearing stage 5 kidney disease, I said, please don't fight with your brother, don't fight with your sister. If anything dispute is there, please ensure that you give up on all those things. Money can be brought, money can be earned subsequently, but most important is an organ. But we are forced to do all these things as well on the later side.
I understand. So I'll take some quick questions now. Somebody is asking that I'm a kidney transplant patient, but creatinine level is not normal. It is around 3.30 mg. So probably seeking an answer to why it is so.
Yeah, see,
after the transplant.
You should know the various other details about this gentleman or this patient, because when was the transplant done? Is it done the recent past or pretty long time? Whether the nephrologist did a test called a kidney biopsy to find out what is the reason for the kidney not working. Depending on that, we can try and tell what needs to be done to ensure that the kidney function is taken care of.
Mm-hmm.
Because it's only an incomplete question what he has asked.
Okay. So now also the other point, after looking at your slides, the impression one gets is a layman would get an impression, would be a little confused that whether it is kidney that dysfunctional kidney that triggers other diseases like say cardiovascular or any other breathing problem, or is it because I already have a pacemaker, I have a stent, and I'm having some other problems that is leading to my kidney failure or progression in kidney dysfunction?
Both are true.
So which is
both are true. In fact, a patient who is a diabetic or hypertensive could have combined heart and kidney disease. A patient with kidney disease, because of abnormalities in the fluid mechanics and the various waste products getting accumulated and so on and so forth, low hemoglobin, calcium abnormalities and so on, could have other organ dysfunction also. In our body, it's not one organ works independently of the others. It's always an interdependency is there. So either way is possible. It requires a combined effort by the appropriate specialist to see which is the primary event causing the other organ dysfunction.
So back to Dr. Rajarajan, based on his slide presentation, if one is a healthy, normal individual, what does he have to do to prevent kidney injury, acute kidney injury?
You see, the last slide which I put forth is to have a healthy kidneys around, you need to have certain maneuvers, like you should have a regular exercising, you should maintain a regular ideal body weight. Actually, there should not be, your body weight should be not fluctuating, and drink as much as of water as possible, around 2.5 to 3 liters of water. Avoid smoking and alcohol consumptions. Don't take any over-the-counter medication by yourself, like commonly prescribed painkillers. Dr. Abhirami also used in his lecture. Painkillers, even your pantoprazole or ranitidine for the ulcer complaints, don't take without your doctor's prescription. And foremost important is to have the kidney checked for the patient who are at the risk of kidney disease, like diabetes, hypertension. Once again, I'm repeating: diabetes, hypertension, obesity, elderly persons more than 60 years, and those who have a family history of kidney disease. Please check your urea, creatinine, and urine for albumin on the time of diagnosis, and every 6 months to 1 year. So this will yearly identify your early kidney problems, and if it is identified, it can be slowed, the progression can be slowed, and most of the time in its economically productive life can be spent without dialysis or higher fine medications. So these are all the
Rajeshwari, yeah, sorry. So Rajeshwari and Gopi are asking about a helpful diet for kidney patients. What are those specific foods that have to be avoided?
Abhirami, can you take the question?
Yeah, I think I talked about it earlier. It is very individualized. It is not possible to give me a diet which fits all. So the main thing is it depends on the extent of your kidney function, the GFR number I talked about, and also how the balance is for the salts and the minerals in the body. It also depends on the blood pressure. It depends on the amount of urine you make. So the main things which we are watching out is for water, salt, protein, potassium, and phosphorus. So the water intake depends on the urine output. The rough thing would be to how much ever. What I'm saying is for the patients with kidney disease. I'm not talking about normal people. So the water intake would depend on how much urine you're making, plus 200 to 500 ml, depending on your lifestyle and where you live and the climate. Salt, any healthy person also should take only 5 grams salt. And one thing I want to highlight here is the salt which we use is sodium chloride, whereas the urea creatinine also we call salt. That depends on the kidney function. So I have a lot of patients confusing between these two salts. And sometimes there are patients who require higher salt, but they won't take, and they come back with low sodium levels in the blood in a much more critical state. So the two salts are different, and chemically, like in chemistry, we call everything as a salt. So what I'm talking about is the salt which we eat, sodium chloride. It again depends on the amount of urine you make, whether you have any swelling or you have high blood pressure. If you make less urine, if you have swelling, if you have high blood pressure, the salt level has to be reduced. For the others also should not cross 5 grams. Unless you are losing salt in the urine, in that case it will be more. Why I'm saying all these is I'm just telling you it is not one fit for all.
Yeah, that's true.
Protein is something kind of common for everyone. Once your kidney function starts declining, the protein digestion, whatever end products we get, that is mainly sent out of the body through urine. So we want to restrict the protein, but at the same time, it should not compromise your health. So we need protein for bodybuilding and for maintaining cellular structure, tissues structure, everything. So that according to their weight and height, they are given some number. You can take so much of protein. Potassium and phosphate, as I said, depending on your blood levels, you will be advised some restriction. Right. So it is better to consult a nephrologist and a nutritionist, more importantly.
To add to Dr. Abhirami's question, answer, she has wonderfully spoken about the diet. In protein, as far as protein is concerned, there are two types of protein we have. That is, one is biologically high available protein and biologically lesser available proteins. Like Your egg is a reference protein where you have 100% of protein will be taken up for building exercises, and protein won't be leaked out of your kidneys. So milk, eggs, and fish, and in vegetarian, that is soya beans, and all have the highly bioavailable protein. So these protein can be taken freely. Whereas if you take a red meat, that is mutton, chicken, and all, your biological availability will be less than 40 or 50%. So this remaining amount of protein will be leaked and causes further damage to your kidneys. Just to add the point.
Thank
More
you.
to add?
Yeah.
One more. See, many times all the books write about protein restriction, and these books are written by the Westerners, and the protein, what they mean is a predominantly animal protein. Most of the patients who are vegetarians, we don't even consume the normally required protein in the diet. For a vegetarian, the vegetable protein, they need not be restricted.
Mhm. Thank you, sir. So, Mr. Suresh Kumar Raja is saying that nowadays kidney diseases are rising in the young population, and also perhaps without any common causes like diabetes or hypertension. So, could you elaborate on that? Like, is alcoholism, like you mentioned, smoking is definitely a big risk factor, but is alcoholism also kind of causing kidney diseases more in the youth?
Ravi, take it.
Yeah, alcohol does not directly affect the kidney function, but alcohol is a risk factor for high blood pressure. And
It's interrelated.
yeah, it is interrelated. Apart from that, when you are consuming a lot of alcohol, you should start worrying more about liver disease, and liver disease is also a risk factor for kidney disease. So just because alcohol does not cause directly kidney disease, no one would accept alcohol is okay. But coming to his question about people developing kidney disease without diabetes or hypertension, in India, we do have a big chunk of that kind of population compared to the West. And one of the theories is the over-the-counter medications and alternative therapies, things which are taken without guidance. We should understand nothing is harmless. Everything is harmful if you take it inappropriately, or you take the quantities different. So in India, we do see a huge chunk of population not having diabetes and hypertension, having kidney disease. I personally think it is related to our practice of taking a lot of self medications. Apart from that, there is one another group which I should highlight because I practice in the periphery. There's something called CKDU, which means just unknown etiology. But now we are beginning to think it is because of, it is mainly seen in farmers working in sun. So the farmers working in sun, if they don't take water adequately, this is something we are beginning to realize only now. So water intake, especially for people who are working in sun or laborers, it is important. I think they do contribute to some of those people.
Mm-hmm. Does it also affect, because you did mention the age group of 40 to 50 years perhaps being more vulnerable or standing the risk of, getting kidney malfunctioning? Because Mr. Krishna Prakash is specifically telling about a 7-year-old niece who suddenly one morning woke up with her face swollen, unable to talk. And of course, she was rushed to the hospital where she was treated without any, what he writes is without guarantee she was treated, but by God's grace, she recovered. So he wants to know what is the reason for such a severe kidney problem at this age, 7-year-old.
Probably the child has something called a nephrotic syndrome, where the face got swollen, some kind of nephritis. It may not be a kidney failure. There are some, we covered only a few aspects of kidney disease today. The child would have had another form of kidney disease which can be treated, basically one. To add to what Dr. Abhirami had told, beyond long-standing diabetes and high blood pressure, there are enough and more diseases specific to the kidneys that can cause kidney failure in relatively younger children. Some abnormalities are congenital. They could have, their children unfortunately are born with congenital abnormalities in the urinary passage that can also cause kidney disease in the young.
Is diet in any way directly related to more incidence of kidney stones these days? Another question.
Not really. See, the stone's a different concept altogether. There are certain people who are vulnerable to stone formation. Different types of stones are there. And either these stone forming substances like calcium, oxalate, and uric acid and so on, either there can be high in the blood or in the urine, they can form stones. Generally, people who live in a hot climate who do not drink much water, the stone forming substances could easily precipitate. So I think if somebody is more prone for stones, especially they form repeated stones, they should ensure that they drink adequate water on one side. And second thing is the reason for why they're forming stones repeatedly has to be evaluated.
Avinash Saravanan is asking about an update on artificial kidney available in India.
It is not yet been approved even in any part of the world as of now. In the US and in California, I think is getting onto it. People say it will come in the near future. What they try to do is they try to see dialysis does only the waste product removal from the kidneys. It is not doing all other functions what we discussed earlier. So they try to incorporate the certain cells inside the kidney along with the fibers, which will do the filtration procedure. That's a basic thing of the artificial kidney. It is not yet approved in any part of the world.
Dr. Selvaraju is asking, you did mention that sometimes other drugs we are taking for other diseases, antibiotics, they can also cause kidney dysfunction. But medicine taking for erectile dysfunction, does that also affect the kidney functioning?
Not really.
No, not really.
No.
Okay. So what I'll do, because we are also running out of time and there are a lot of technical questions, a lot of very, very specific questions where people have mentioned what tablets they're taking, what medication they are on, what has gone wrong. So I think we will ask our team to forward those questions to you and perhaps you could email back the answers to our participants.
Sure.
And since we have already overshot our time, I would like to draw the curtain on this very nice, very, very informative discussion with all three doctors, Dr. Balasubramaniam, Dr. Abhirami, and Dr. Rajarajan. Thank you very much. And I hope today's webinar presented jointly by Kauvery Hospitals and the Hindu will help all our listeners take charge of their kidney health. I thank you all once again.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you.